Good evening, everybody. Welcome to our webinar, A Functional Medicine Approach to Menopause. My name is Dr. Indra, and we have Dr. Ailsa with us here today from the practice. And we have Laura, our health coach, also with us as our team today. So today there's an hour we've allocated for this webinar. We are going to be speaking for probably about 35-40 minutes. And we are going to be talking to what the difference is between a functional medicine approach and a conventional approach to menopause care. What are the top tips that we are seeing a lot of in the women that we are supporting? Dr. Ailsa is going to be speaking to BHRT and bioidentical hormones, what that whole space looks like and feels like, and what we are offering at our practice. And Laura, our wonderful health coach, is going to talk to you about why having a health coach to support you through menopausal changes is such an important part of what we see is really key to transforming your health and well-being. So I hope you enjoy our presentation today. Do put in any questions into the chat on the side. If you want to keep it anonymous, you don't want to say who you are, please then just message myself or Dr. Ailsa directly, and then we can answer those questions towards the end. Okay. Right, so a functional medicine approach to menopause. I'm going to be talking about, well, before I say that, the housekeeping. This is obviously a webinar. We're not really providing any medical advice, to make sure that if anything you hear from us, you do check it out with a health professional before you make any changes. So today I'm going to be talking about two different things. One is about the difference between an NHS and a functional medicine approach, to kind of highlight what is involved in what we do at our practice, and also a key area to focus on for our women that are experiencing menopausal symptoms. I actually started off having 3 key areas, and then I realized there's actually one key area right in the middle of all of this. So hopefully that will come across in what we're talking about today. So me sitting in my NHS GP practice, I'm going to start with a 47-year-old lady who's feeling tired, who's feeling anxious. Her period's a little bit more erratic now. She's been on and watched Instagram, read Davina, and thought, right, actually, I think maybe hormones are the issue of why I'm feeling the way I'm feeling. So could I prescribe her some HRT? So what do I do in my GP practice? So I have 10 minutes, as you're all fully aware. I would have had a quick look at her notes to see what other medication she's on and what other issues she's come to us with prior to this. So I would ask her the questions, find out more about the anxiety, more about the tiredness, and make sure there isn't any sinister things going on. And that's one of the key things that GPs do. We make sure there's nothing life-threatening that we need to be dealing with quickly, rather than more a chronic issue. So take a history, I'd examine her, make sure that their blood pressure is okay. And in a history, we'd be looking for any issues with blood clots or a past history of ovarian cancer or any kind of cancers in the history or family history of cancers, which I know there's a lot of conversation going on about that, and that's just limiting a lot of people getting medication. So we've done that, we've examined her, and as a GP, I might think, okay, with her tiredness and her anxiety, I just want to make sure that she's not deficient in anything, and maybe do some initial blood tests. Not all GPs do this. There isn't any guidelines to necessarily do all of this, but just to make sure that there isn't anything that we're missing regarding her fatigue, we'd do some blood tests. I would then discuss with her what I found, what we think could be the problem, and discuss maybe the benefits and risks of HRT. And we would then say, okay, made a decision together, we'll try HRT. So I would prescribe HRT. and probably give her 3 months worth and then let her go and then maybe see her in 3 months' time. So all of this takes place in 10 minutes. Well, it doesn't. I don't think I've ever done that in 10 minutes. It's more likely to be about 15 or 20 minutes. And I would probably be running late as usual for medics of what the kind of doctor that I am. So she would go away, she'd maybe have some blood tests. She may hear back from the blood test. If it's normal, she may not hear anything. And then 3 months later, she may come and see me again. She may not come and see me again. It may be just a telephone call and then off she goes. That sound familiar to people? I think it's pretty common as to what happens. So now I'm going to shift into my functional medicine clinic. Another lady in her 50s. She's been struggling with hot flushes and mood changes. And one of the biggest things I hear from a lot of our patients is that they just don't feel themselves. Something has changed. They can't put their finger on it, but something isn't quite right. She's actually managed to go to a GP, has tried HRT, but still isn't feeling great. She's read about bioidentical hormones, and she says she wants to start to work with someone who can prescribe her bioidentical hormones. So what would I do with this lady? So the first biggest difference in functional medicine is we spend 90 minutes with you in your initial consultation. We want to know everything that's happened to you to get you to this point, from birth all the way to where you are now. And why is that important? Because how you're feeling in this moment in time is the result of everything that's happened to you in your life. We want to go back to the beginning and understand how you got to where you've got to. Now, we're not really attached to what's happened to you, but we want to understand, how does your body respond to life events that you've experienced, and how has it shown itself up to you? The other reason for us really focusing on this history and understanding from birth till now is that everything in our body is connected. So if you've got a gut issue, you've got a mood issue, you've got a thyroid issue, you've got a joint issue, every single one of those things is interconnected. And when we're talking about menopause and we're talking about the hormones, there is a massive dance of hormones that's happening within you, from your brain to your thyroid to your pancreas producing your insulin, all your sex hormones, all your adrenal hormones. They're all communicating with each other constantly. So we're not just working on estrogen, whereas in conventional medicine, we are really just looking at your estrogen. So we've taken a history. We have examined you as well, like we would do, but the history is looking for the root cause. In functional medicine, we are really figuring out that inflammation is the root cause of all chronic illness. What is inflammation? It's your immune system seeing danger, whatever that danger is, going out there, dealing with the danger, and then coming back to normal. If your immune system is chronically activated, it creates inflammation. A way to think about it is maybe like a fire that's kind of constantly smoldering in your body. So we are looking for sources of inflammation in your history. The key areas for inflammation in any woman or any person is nutritional deficiencies, stress, toxins, allergies, and chronic infections. All of these things we are looking for in your history. So we have spent time looking at her history. We will probably do testing. The testing is to find out those 5 things, how are they affecting her body? Does she have all the nutrients that she needs for her body to work effectively? Does she have the right kind of hormone profile? What is going on with the hormone profile? We might do a urine test to look at how your body's actually metabolizing the hormones. So that's what we do in a functional medicine consultation. We examine you, we do a history, we do a blood test, and we often do urine tests to check the hormone profile. All of this in 90 minutes. And then you'll be reviewed again for a further 45 minutes to review all your test results. And how is that different? First of all, you're seeing somebody to actually look at your results. And in functional medicine, we really want to look at optimal results. So for an example, you have iron, ferritin, and a lot of women have low ferritin with problems with their periods and that kind of thing. Conventional medicine will say, okay, your level is say 21 or 22. The lower end of normal is 20. How do you think you would feel if you're just at that lower end of normal? Probably not very well. So in functional medicine, when we're looking at your results, we're making sure that you are as optimal as you can be. We want your ferritin to be closer to 70 or 80 rather than anywhere now down in the 20s. So we've got a history, we've examined you, we've got blood results, we've got the testing results. We then look at all the modifiable lifestyle factors that can help you make your body work more optimally. So we will start to then look at your sleep, at your movement, how you're eating, and your stress management. This is how we would be managing your menopausal symptoms. Once all of that has been looked at and we understand all the different aspects that are in your profile, we will then be looking to see whether or not hormones is part of our treatment profile for you. We use something called a matrix that looks at the whole 360 of the patient. And once we've cleaned it and we've made sure that all of those areas are nice and tidy, what we tend to find is that people that start off on some hormones end up actually reducing the amount of hormones that they're needing to use. So those are the big differences. We've got more time with you. We're much more interested in the whole aspect of you. We're also interested in your lifestyle factors that can help you manage your body and how your body works, finding ways to reduce your inflammation. And we want to optimize you and not just make you normal versus abnormal. So the next part, what are the key areas that we find in our patients? Blood sugar management and stress. And I just put the line at the bottom there. Menopause plus inflammation equals symptoms. We're all going to go through menopause. There is always going to be changes in how our body works. But if it's sitting on a level of inflammation, we are going to experience symptoms much, much bigger. Why have I pulled out blood sugar management and stress? Actually, the key part of all of this is your stress management. Because the stress hormones interacts with every single part of your body. And when we're thinking about, when we're thinking about stress, that is what triggers your hot flashes. The lower estrogen resets your temperature regulation within your body. So it's the adrenaline that's rushing around that actually creates some of your hot flushes. So stress management is very key. So how does stress management link to blood sugar? Blood sugar in your body is how your body helps to digest your carbohydrates that you're eating and the sugars that you're eating. Now, we all know we live in a society where if you go to work, and I know in GP land, there will be a cake or a chocolate or something. You're rushing around, you wake up early, maybe grab a coffee, go to work, there's a cake or something, you have that in. As soon as you start doing that, your blood sugars start to go on a roller coaster ride. The ups and downs of your roller coaster causes anxiety, causes hormonal changes. And the ups and downs of your roller coaster affect your estrogen metabolism. So they are definitely part of the picture of how you can manage the symptoms of menopause. It was really interesting. I've been doing a nutritional plan myself where I've been eliminating sugar for a number of health reasons. And I ended up having a muffin that actually was a homemade muffin. And I decided I was just going to let go and just eat whatever I wanted. That night, I actually woke up with a massive hot flush. And I don't normally get that. And I was like, oh, this is really quite interesting how blood sugar affects your the hormonal system. And the third point that I really want to make before I end is that when we're dealing with stress, one of the key things can help with menopause and hormones and your estrogen level is movement. Movement with increased muscle strength or resistance really helps with mood and also balancing your hormones. And it also helps with blood sugar management as well. So what can you do about it? Find ways in your day to have calm and contentment. That is managing your stress. Find ways in finding joy, love, connection, calmness in your day. I'm going to let Leora talk more about that when she talks about managing stress. Balance your plate. Become curious about how sugar affects you and your symptoms. It doesn't have to be anything. Just really start to notice how you feel after you've had something that's high sugar. Find movement that brings you joy, even if that means putting on a wonderful piece of music and dancing away like you've never danced before can absolutely help to strengthen and make you feel better in yourself. Thank you very much. We will go on to Elsa's presentation now. Hope that was interesting to everybody and learned something a little bit new, but please, if any questions are coming up, please do pop them into the chat down below. Elsa, I'll hand it over to you.
Thank you. I'm just going to share my screen. There we go. So hopefully everybody can see that. So this is about the difference between HRT and BHRT. So what's the difference? So just a little bit about the history, because people might think that BHRT is a new thing, but actually bioidentical hormones have been around since the 1930s, and they actually predate the synthetic hormones. But then sort of 1940s onwards, the synthetic hormones came in, and that they were the new latest thing. And these synthetic hormones were actually derived from pregnant mares' urine. But the thing about those hormones is that although they're very similar to our natural hormones, they're not exactly the same. Yes, they more or less fit into the hormone receptors, but it's not an exact fit, which means that they can have other effects, side effects. That's often why people maybe don't tolerate them. So then in about the 1990s, bioidentical HRT started to be used again, but just by a small number of physicians. 2002 was the Women's Health Initiative, a big research study, and that suggested that a combination of non-identical estrogen and progesterone could increase the risk of cancer, heart disease, and other health problems. And I certainly remember that working in general practice, that there was a massive drop-off in the women coming for HRT. Before then it was, oh, you're menopausal, here, have some HRT. Everybody was on HRT. So all of a sudden, lots of women were really worried about these potential adverse effects and started to come off it. 2012, they re-evaluated the data, and they actually realized that it was the artificial progesterone, the progestins, the ones that aren't exactly the same as our natural progesterone, which increase the risk of cancers and so on, not estrogen on its own. In 2014, NICE guidance came out that said that HRT was more beneficial than harmful, and there was no maximum duration of treatment. it was really about symptom relief, but maybe to consider reducing the dose with each decade of life. I mean, certainly I remember in my training that we were told 5 years maximum, then they have to come off. But actually, is anybody listening to what the woman says and what her symptoms are? Lots of women say, oh, my symptoms came back when I came off the HRT. Oh yes, but your risk increases at 5 years. But that's not thought to be the case now. 2017, British Menopause Society, they identified a lower risk profile using body identical progesterone compared to synthetic progestin. So I'll explain about the difference. So conventional HRT, it's synthetic, it's non-identical. As I've said, BHRT is body or bioidentical. So body identical is standard formulation, pharmaceutical formulations that you can get on prescription. So there isn't the dose flexibility that you have with the bioidentical. The bioidentical HRT is prescribed individually, compounded for every patient to contain the combination of hormones. And the advantage with the bioidentical HRT is that you can add other hormones in, so you can give things like testosterone, DHEA, pregnenolone. So as I've said, the conventional HRT, it's an imperfect fit to the receptors, whereas the BHRT fits perfectly, which means that the conventional HRT, there's an increase in side effects and an increase in risk. So just to compare the effects of the artificial progestin and body or bioidentical progesterone, so you can see that the body identical or bioidentical has a reduced risk of breast cancer compared to the progestins. It helps to relieve premenstrual symptoms. It improves sleep, particularly. It's meant to be really calming, helps with anxiety and low mood. It has a diuretic effect, decreases blood pressure, improves the cholesterol profile, improves bone density, improves fertility. But the progestins, there's an increased risk of breast cancer, a risk of depression and mood swings. There are lots of women who say, well, I went on the progesterone only pill and it made me depressed. Some women find that it reduces their energy, makes them more irritable, they retain fluid, get headaches. It has a detrimental effect on the LDL cholesterol, may get breast tenderness, bloating, but it might prevent osteoporosis. So this is just a summary sheet from the Marion Clinic on the BHRT treatment options. So you can see here at the top, there's the personalized BHRT with the different hormones that you can put in that. Then there's the licensed BHRT and all the different formulations, and then conventional HRT there. So this is a BHRT pathway for patients coming to our clinic. So we're developing a BHRT service. So patients can choose whether they go down the functional medicine path and look at all of their matrix, or if they just want to go down the BHRT route, they can come specifically to the BHRT service. So we will always send out a pre-consultation questionnaire asking a lot about the symptoms. The initial consultation will be between 45 and 60 minutes long, so a lot longer than a 10-minute GP consultation. And in that, we're taking a thorough history and doing an examination, just making sure that there aren't any contraindications, that we're going to be prescribing safely, talking about the risks and the benefits, and the hows and the different formulations, because it can be delivered in a few different ways. Then after that initial consultation, where you would have a blood test, 1 or 2 weeks later, there'll be a telephone review to go through the blood results and agree a treatment plan, agree what's appropriate. And then at the end of that consultation, the doctor can prescribe the BHRT. So they'll send the prescription to the compounding pharmacy. The patient will register on the compounding pharmacy website. And once the prescription has been authorized by the pharmacist who will check the prescription, they can then order the BHRT and pay for it. Then following that, 8 weeks, at the 8-week mark or 6 weeks later, there'll be a follow-up appointment just to go through how you're getting on with the BHRT, whether your symptoms have settled, whether you're experiencing any side effects. And then at the 12 weeks later, you'd have another blood test just to see whether the hormone levels are okay, and again, review the symptoms. So it's not uncommon to need to tweak the doses of the hormones. And that's the lovely thing about the compounded preparations, is that we can alter the dose. And it may be initially the hormones are prescribed separately until we get the dose right of each one. And then we can combine them into say one transdermal cream. Then there'll be another review 6 months later, and then after that a yearly review. So you can see that there's always a check-in. Once women are stable on their medication, we would just ask for a yearly review and a blood test. So the BHRT consultations, so they can be face-to-face or by video call. Face-to-face, the initial appointment would be 45 minutes or 60 minutes if we're doing the phlebotomy. Phlebotomy is available at the Iveridge Clinic or at Superdrug by appointment. If you were having a video call, we would need up-to-date height, weight, blood pressure. Reviews can be by phone, video call, or in person, whatever your preference is. Blood testing would be after dosage adjustments and at least once a year. Possibly we might order other investigations depending on the history, because we want to make sure that we're prescribing safely. And if any problems such as unscheduled bleeding occur, we might want to investigate that or recommend that you see your GP. So we might test your thyroid, we might do a pelvic ultrasound, recommend mammography. So it'll really just depend on the doctor's assessment. So that is everything from me.
Thank you, Ailsa. So we've got like a functional medicine approach and then a very conventional model of supporting people with BHRT. And it's important for us to make it, clear, but because we're a functional medicine clinic, we are going to make sure that our patients are given the advice about lifestyle and about making nutritional changes, hormonal, all of those kind of things as well. So I'm going to bring in Leora at this point. Leora is one of our health coaches. And, what we have found with using health coaches in our practice is that they're there to really help our patients implement all the changes that we are advising to do. So I think, Leora, I'll hand over to you.
Thank you, Indra, and hello, everybody. Good evening, if you're all based in the evening time zone. It's really interesting listening to both Dr. Indra and Dr. Ailsa speak about menopause, just about this next transition in a woman's life. And I think ultimately, when we look at women, it's often a misunderstood time, and that is in our meeting before we came onto this webinar tonight. That is how I would describe this particular space in time for women. It's often women scurry to whatever the next best thing could be, exactly as Indra described. They have that rushed NHS appointment, and they really do have a unique opportunity here to be heard and to be managed in the way that is most appropriate for them, either to be going via the more traditional way, either functional medicine also, or going via the BHRT method that Dr. Elsa so interestingly put forward, that there's another wonderful pathway that we also have at Dr. Indra. So from my perspective, as a health coach, it's really understanding what is it that this patient needs in their journey. So ultimately, people often ask me, what exactly does a health coach do, and how do we support the patient in making these changes and these lifestyle modifications that they need to? It's highlighting what is it in the prescription from the doctor is most challenging for that patient to implement. And with menopause, often it's a new area that that women have to understand, and a way for them to really get to grips with these lifestyle changes. Maybe they've been enjoying sugar for a large part of their life, and it brings them a lot of joy. Maybe they're excellent at baking, and that's something now they've got to face. Everybody knows my carrot cake and my chocolate cake, and maybe that's not what they've got to eat anymore. How can I tell them that we need to look at alternative options? Or the fact that they get emotional all the time. How are they going to find ways to deal with that if they're in an executive position at work? How are they going to explain that to their colleagues? So there's just so many different things that as a health coach I need to listen for. And what I do is listen. So when people ask me, Leora, what do you do? I listen, and I listen for what the gaps are, and I help people to connect the dots in their very important prescription from their medical doctor. And what really does come up in the menopause space very strongly, and it's seen broadly amongst most women, are issues around sleep and anxiety. And, I could say that there's a specific way that I support women going through this particular time, but sleep disturbance, specifically insomnia, is often a very difficult area for women to manage. And there may be, a list of top 10 tips. You don't need to hear me tell you what they are. You probably all know what they are. But it's understanding, why is it that you know all this information, but you can't do any of it? And then understanding what it could be. Perhaps this woman is sleeping next to her husband at night, which maybe she didn't mention to Dr. Indra, and he's snoring terribly. So that could be something that we discuss. How could they modify a bedroom environment to support better sleep? It could be that through nights, frequent night sweats through the night, that they're waking up frequently, and until they get their medication regulated, they're not actually able to have that quality of sleep, and that's impacting their ability to perform during the day, for example. So it's really a space where I tap into people's purpose, their why, and understand why is it firstly that they've even contacted a practice like ours at Dr. Indra, and they're not just accepting the conventional route that is out there, because at the end of the day, they could go to the NHS and they will get care, but they've come to us for a different type of care. And I'm confident in saying that, in looking at the role of the health coach together with the collaborative care team, we're able to see what are the nutritional contributions that are either positively or negatively impacting how this particular transition in life is taking place. And there's really a reinforcing, a reframing, and a listening to what is it that we need to fine tune, because there's an innate intelligence that women have. Okay, I know that we're predominantly women on this call this evening. Paul, I'd love to know what brought you to this call, Paul. I'm going to ask you actually, but there's an innate intelligence often that women have, and again, it's another chapter that they have to now navigate through again. It can be seen as a hurdle. Or it can be seen as a new chapter. So I think a large part of the training that we have as functional medicine health coaches is in positive psychology. So it's about how do we create this change in a positive way. And that's not about this toxic positivity that is very much out there, but about looking for what is going right with this particular patient, and not only what is going wrong. Because menopause isn't an illness, right? Okay, I'm sure you would all agree it's not an illness, it's the next chapter. Many women are dealing with their children having left home. They're having to find their new way of experiencing life. They may have experienced divorce. They may be experiencing failing marriages. So there's very much a blending of medical, but more about supporting the life transition of that person. And if somebody's busy dealing with a divorce, for example, whilst going through menopause, telling them to go gluten-free and sugar-free may be a really hard thing for that patient to implement. I'm sure you would agree. It's really about listening to where that person is at and supporting them. Some of our patients at the practice are with us for a shorter period of time, maybe for 3 months, they spend time with us and they're well on their way. But there are other patients that are with us for longer, where their menopause transition may be an important support that they need. And I'm very grateful, and I always say that my work is a privilege, where I'm able to speak to people and guide them through this change in their lives. So I'm just referencing my notes if there's anything that I've forgotten specifically that I wanted to mention. But I would say that stress management, self-care, a sense of community, and then dealing specifically with sleep and anxiety are the kind of the key areas that I've noticed in dealing with women going through this change. So I'm very open to questions about it, but I'm going to hand back to Indra. But before I do, I want to just ask Paul what I have to ask Paul as the only gentleman in the room. I'd love to know what brings you to this call this evening.
Yeah, no, Sean. Good evening, everyone. So I put a weekly blog on Facebook that sort of outlines just what's been going on in my general week. And I work for a large NHS trust in Manchester as a senior manager there, and we're trying to become a menopause friendly organisation. So I recently did training to become a menopause advocate, and I wrote about that on my Facebook, and a colleague that I know said, "Oh, this webinar, you might be interested, maybe." So I was interested to see if actually was anyone's joining, because I've been running sessions all this week trying to raise awareness about menopause and perimenopause in the workplace, and actually put this link into that to see. So I thought, well, if I thought I'd come along, find out, because again, we're trying to raise awareness for all our staff. I'll shut up in a minute, but our organisation, we've got 28,000 staff. 80% of our workforce are women, so we've got significant numbers. And as you've already alluded to, the provision for support is really, really poor. So I'm really keen. It's not my primary job in the NHS, but I'm really keen that we start getting parity with things like musculoskeletal psychological wellbeing services, that we try and get that for our staff. Because if we can't do it as an NHS provider, then who else can? So that was what brought me to see what else I can learn, what else I can potentially then look back in terms of, what could we fund for our staff, etc. So that's what brought me here tonight.
Thank you, Paul.
Well, that's amazing.
Yeah, it's amazing, and I'm sorry to have
singled
you out.
No, not at all.
That's amazing. Sorry, Indra, back to you.
Thank you so much, and it's lovely to hear that people are exploring what this whole space is about, because there is so much more than just the hormones, as we have seen and we've talked about. And actually, this is about a whole overall well-being. So I'm going to open this out to any questions that people have. And I'm also going to invite our psychiatrist on our team who's here to also join us on the panel if you're around, Pratima.
I am.
Just want to introduce everybody to Dr. Singh, who is our psychiatrist on our team. And we did ask her to sort of think about menopause and psychiatry, and she's like, oh, okay. But, mental health is such a big part of changes that happen to a woman as they go through this part of their life. So, yeah, does anybody have any questions? There is a private question that I've been asked about private medical insurance. We're not linked to any insurance companies at the moment because they don't quite understand what we do. And we're trying to make sure that we stay as a collaborative care team, even though we're kind of bringing in the conventional BHRT route because we know that there's a need for it. And it's something that we want to be able to provide to our collaborative care model that we are utilizing. So we have tried to be in touch with people like Vitality, who kind of understand what we do. But if anybody knows anybody higher up in Vitality that want to put us on their books, please do tell them to get in contact with us, because we would be happy to work with them moving forward. Paul, please.
So again, I learn about the BHRT tonight. Does that get prescribed? Does that ever get prescribed from an individual practice? I imagine not, given the work that you do to actually work out how individual that comes. And I suppose how far are we away from that sort of being a service kind of that people would get? Because obviously that is very, very specific to an individual and will cost a kind of accordingly, really. So it's how
it's actually not massively expensive, but it's not available on NHS prescription at the moment. The nearest is the body identical, but the potential issue with that is that you have to prescribe the estrogen progesterone separately. So they may have an estrogen patch or a gel or a cream, but then they have to take a progesterone by mouth because they haven't got a delivery system for it transdermally.
And with the bioidentical hormones as well, they actually have to be prescribed off license because they are given specific to the women. So they're not under the MHRA regulations. So all our women have to understand that and have to realize the pluses and minuses relating to that. Does anybody have any other questions? I was just going to maybe reach out to Pratima and her role as a psychiatrist. How does she think about menopause when she's looking at her patients?
Yeah, I think so. Menopause is often probably sometimes the first time that the woman might present to a mental health service. But I think the trend usually is, Indra, as you've already explained in your presentation, the rocky your kind of cycling time, the rockier the menopause. But I think what's really unfortunate is sometimes the first time women are hearing about this is when they are in that transition. So for example, I have got somebody with a diagnosis of bipolar, a very difficult kind of traumatic life. And now that she's hitting menopause, it's a bit uncertain. Yeah, she's been off medication for a number of years, she's so concerned that it has been so unmanageable. She might have to go back to medication. And looking back at her history, she has everything. She's got heavy periods, she's got postpartum bleeding, all endometriosis. So a very clear-cut history from our point of view, that she has been in this hyperestrogenic state throughout her life. And one might think how much that might have contributed to the so-called bipolarity and the extent of mood fluctuations. Because, to be honest, yes, I think the clear-cut bipolar can be very easy to spot, but then there are all those kind of variable mood cyclothymic presentations, which are definitely impacted by hormonal change. And these will present in practice with a description of, oh, I'm a completely different person 2 days before my period starts, or I just, and usual response to that from conventional medicine would be, oh, you can just, go on the OCP pills and stop cycling. And that creates its own difficulties. In the younger age group in mental health, for example, many of our younger patients who start the combined pill, we often see that irritability, which can make the clinical picture very clear about what their baseline mood is. And as we know that these contraceptive methods are used earlier and earlier, so it can really complicate what a young person's baseline mood is. And for a group of young women, it just does not work well, and they might not appreciate that they are now getting a new psychiatric diagnosis for something that might be a mismatch between their biology and the treatment they have been offered. Yeah, so we do see that a lot.
I think that's really important to recognize. And the functional medicine model is about the whole picture. And we know even for, in the mental health spectrum, we know that body inflammation triggers brain inflammation. And now we know that inflammation on top of menopausal changes just enhances the whole effect of what everybody's going through. Yeah. So just knowing that and being kind to ourselves, which I think is a big, big question for a lot of women, is just, again, like what Paul is saying, knowledge and awareness is such a big part of it, because once you're becoming more aware, you can make changes. And that's what, even with what Leora's doing as a health coach, is listening in. And the fact that they've made the choice to come to a practice like us means that they want to change. And that's so important. Also, with you prescribing HRT, we all do prescribe HRT. Have you seen any key differences that working from a functional medicine model and then adding HRT that has been really important for you to see?
I think certainly just, as you say, balancing the whole dance of hormones. Often maybe people don't even need to have the hormones, the prescription hormones. And I think you can use lower doses as well.
And it's one of the things that we see in a lot of our patients is managing the nutrition side of it, as well as the gut health and all of these things that we haven't really covered today. I know one of my patients started off wanting HRT. By the time we've finished sort of sorting out her gut and her sleep and all of these kind of things, her HRT dosages have come down, and now she went off them for 6 months, but then her stress levels increased and then she had to go back on them. So there is a definite, not everybody needs hormones, but definitely management of their lifestyle factors is very key to supporting the whole picture, really. Leora, did you want to come in?
Yeah, just it's exactly to that point, Indra, and it's the connecting of the dots, and I think the functional medicine approach as a whole is putting the patient at the center. And when you put the patient at the center, all aspects are considered. It's never just one variable that's going to kind of shift the needle. We're needing to look at gut health, inflammation, we're needing to look at sleep, we're needing to look at who are the people that are caring for this person. If they're speaking to the NHS GP and they're speaking to us, and they may be going somewhere else for something else, that's what I like about where we are. There's this opportunity to have this kind of thorough knowledge because we're able to spend time with people. So I think that's a big advantage that we have. There's the space and giving people time and space to be heard. I think especially at the menopausal stage as well, Indra, is a very important piece. So I find that the further along the chain sometimes we go in terms of how we work, the depth of that person comes forward, and then we're really able to help them. So
definitely. Paul, your question, have you seen with FM approach a reduction in prescribing antidepressants? I'm going to hand that over to Dr. Singh, because the overwhelming response is yes.
Sorry, what was the question?
With an FM approach, a reduction in prescribing antidepressants.
Well, I mean, to be honest, people who are even aware of the functional medicine approach will not go down the antidepressant route. But, this is where the guidelines don't help. So, for example, Maudsley have a specialist kind of, what is this fancy clinic called? It's run by Professor Michael Craig, where they see women who have this. And they, in my observation, the main kind of intervention is an antidepressant. And, when you have that approach, you will find the research behind it. But I mean, I've not seen it help that much, to be honest. I mean, it does kind of help symptomatically in some, but it's no comparison to what we do here. And many people even coming to functional medicine would often come, for example, when the GPS said, yes, like every 3 years, you will have to go through this laparoscopic kind of removals of your endometriotic patch. And then the penny drops that, this is not what I want to be, or, somebody saying, okay, just get, it's a few years, then we can get rid of your uterus, as if that's an intervention. So that is where, and similarly for mental health, I mean, people would probably not make that connection, as the example I gave earlier. People would come to functional medicine during menopause with an awareness affecting when it is really severe and they want to avoid going down a route. So, generally these are patients who are very well aware about how difficult it can be coming off some of the psychotropic medication. But at the same time, I mean, I don't think it's an either or approach. I think we have to optimize and, like Leora said, ultimately look at the person holistically and see, what is going to enable them to live a life and, fulfill the roles that they have. So both those interventions might have a place.
I just want to ask everyone that's here, if you just put into the chat, what was the main, I know we know what Paul's reason is, but what was the reason why you arrived today at this webinar? What were you looking for? Have we covered all what you were hoping for in our webinar? That would be lovely if you could just put that into your chat, because we want to make sure that our webinars are informative, practical, and connecting you with a different way of working. We're not saying that NHS is bad or worse or anything else, but we're saying that we want to work together with our patients to provide a service that's very individualized and what they are looking for. So if you just spend 2 minutes just to type into the chat what kind of things you were looking for today.
Indra, while people are doing that, another thing that comes to mind in terms of mental health presentations is cognitive problems. So another observation, just kind of seeing women probably in menopause or a few years after, if people have spent, much of their cycling lives in hyperestrogenic state, you see this kind of very sharp decline in their cognitive function because, the brain just needs progesterone. And I found that quite classical because, they are still at least 10 or 15 years away from the classical dementia picture. And we get those referrals who go through the shebang, because 3 days I work in NHS, everything is right. And if you don't find anything, it's put down to depression because, now with, those cognitive difficulties, change in mood, I think it's a bit of a misuse of that diagnostic label. So, and I think that worries me because that is such a crucial point to intervene where, the woman has kind of finished this phase of life and the lifestyle and nutrition, hormonal health could be really supported to have a very fulfilling, like post menopausal years. And I think that often can be an opportunity lost.
Oh, that's brilliant. Thank you, Prathama. I mean, I think hormones is one of those things that we are now working with when we're dealing with early onset dementia type issues as well and other cognitive difficulties. And that's part of a protocol that Dale Bredesen has created as well, looking at how hormonal health can really help and boost and support brain health as well, which we haven't really touched on today, but that's part of why women are having problems with their cognitive capacity as well. Thank you to everybody that's put on here to support of the lovely MDT. Thank you, Lynn, for you working as a health coach, and for Surachki, just interested in how we work, interested in getting tips and lifetime in terms of modifications that can make managing menopausal symptoms. I think the first thing here, Surachki, is to look at your stress management and making sure that you are doing what you can to improve that. and blood sugar. Those are the two key things to look at. And then further down the line, we can look at gut health and all of those other things. Those two things can really affect your blood sugar management, especially when it's dealing with hormones as well. Preet, simple lifestyle changes for the menopause or supplements. So again, from the lifestyle changes, I would suggest those things: managing the stress, breathing techniques that can help the vagus nerve, support the vagus nerve is massive in helping manage your hormonal symptoms, and supplements. Ailsa, did you want to take that? You're muted at the moment, Ailsa.
I think healthy fats is really important because all of our sex hormones are derived from cholesterol. So not fearing fat, but eating the healthy fats that occur in nature is really important. Vitamin D is important, antioxidants.
One of the things I learned recently, that vitamin C helps to metabolize progesterone. I was like, oh, okay, that's interesting.
And things like cinnamon are useful in balancing blood sugar.
Yeah, all your B vitamins are really important in
B vitamins,
metabolizing your hormones and utilizing them.
Yeah, I just wanted to make a comment just to what it must be like for somebody perhaps to be on the other end of all of this, where, you know, if there's the traditional medical model approach that's available to them, and then there's this whole other way of doing things, that a lot of the decisions that are made out there are people that maybe are in a Facebook group, and then they get a recommendation about something, and then they start doing a little bit of this and a little bit of that. And I think the biggest thing here for me is that not only from a functional medicine practice perspective, but it's about for women that are going through this particular transitional period, it's about having that holding space where there is a doctor that is the prescribing person and the person that is actually guiding the process. And then there is the implementation on the other side of it. And I think it's almost like you can say to them, they can stop Googling for a little while. Don't check out what's in your friend's medicine cabinet when you're there and what she's doing because she looks so good. It's offering them another toolkit and opening that up and saying there's a lot more that you can do. And I know there's hundreds of things that you could do, but we're going to narrow it down to these 5. So I think that's the real benefit that I'm hearing here, is because if I were to be hearing this conversation for the first time, it's this need to be guided by somebody through what is a potentially alternative way still for people to go through their menopause support. Anyway, just wanted to add that in.
No, I absolutely agree with you, Leora. We're just kind of pushing out little tips and things like that, and this is why we say yes, but actually there's a much bigger picture, and it may not be right for you, because if I suddenly give you vitamin C and you've got an oxalate issue, you might be really feeling unwell. You know, we don't know where you're sitting at. We want to understand the overall picture of each person that's in front of us. Jade, you said seeking an alternative approach, concerns over what's going on inside my body as someone who has celiac disease and has worries over vitamin and mineral absorption. I think that's wonderful, Jade, for you to come here today and hear about what we're doing. Gut health is one of the core things that we are doing at our practice, making sure that whether you have celiac, whatever your state of your gut health is, we are really wanting to make sure that digestion is good, that you're chewing well, you're absorbing what you need to, because that is the central part of how you get your body's information. If that's not healthy, you are going to struggle with a number of things, and that is where 90 or 80% of your immune system is sitting in your gut. So if there's any issues there, then that's where we always start, generally speaking. Ailsa, did you want to add anything?
I mean, if anybody's interested, I can give you a little bit of information about the different types of BHRT, the formulations, the way it's delivered, and what it might cost if anybody's interested in that.
No, that'd be good. Thank you.
Yeah. So BHRT comes in a cream, so it's a pump formulation. So all you do is you squeeze a pump's worth onto the inside of your forearm, and you just rub it and rub it and rub it and rub it for about a minute until it's all absorbed. So that's transdermal. There is also this, which is called a ticker device. So it has a cap that you take off the top, and then you put a syringe on the top like that, and then you just turn the bottom and it clicks. So your prescriber will tell you how many clicks, and then it squirts it up into the syringe, and then that's applied transvaginally. So that's more for localized symptoms, so vaginal dryness, urinary symptoms, that sort of thing. And then you can also, there are sublingual lozenges, so they come in a tray like that, and you might start with 1/4 of a lozenge. So it comes with a tablet cutter. So if you're using the lozenges, 15 lozenges, so that would probably last you 2 months. If you were using 1/4 with 2 or 3 hormones in, it's 79 pounds. So if that lasts you for 2 months, that's less than £2 a day. If you're looking at the creams, so 160 doses of the transdermal cream is £116 with 2 or 3 hormones in. And you usually use it twice a day. So that would be 80 days worth. So again, it would be less than £2 a day. So people think that it's really expensive, but it's actually not that expensive if you compare it to having a Starbucks coffee every day.
Improving your life. That's
yeah.
We've got a few more questions here. Thank you, Ailsa. Does the MDT approach potentially then look at how partners can support tools and techniques, making sure they understand and support can no doubt reduce stress? Absolutely. Especially with the health coaching appointments, they're looking at the whole environment that the patient is sitting in and seeing what else is triggering. I mean, we've had in our practice, we have a once a week an MDT, we call it a collaborative care meeting. And we talk about what each patient has come through, if there's any issues. And some of the conversations that I have with a patient is so different to what Leora and her counterpart have. And we learn so much more about what else is going on in the patient's life, rather than us sort of sitting here going, well, you need to take 20 supplements. And they're like, well, there's work going on in my house. I don't have a bathroom. I don't have a kitchen, and all of these things, which they won't necessarily speak to the doctor. But implementing what we're asking is where the magic happens. And if you can't implement it and you get overwhelmed and you decide to go off, then you're not really going to see the benefit of working within a team. But having a conversation with our health coaches and them understanding the much bigger picture than just your biology is key to allowing the change to happen. So Lynn, you've got a paid for menopause webinar. What's the content? Yeah. So the webinar that we've got is run by our nutritional therapists who couldn't be here today because they're such a key part, and we've kind of missed them in this whole team approach to menopause. So Kim is doing a webinar called Diet and Menopause, and she's going to be focusing literally just on the nutrition side of menopause and what you can do to actually help with your menopause in how you're eating, what you're cooking, your foods and everything that can be really useful to helping you. So if there's no other questions, I'm going to wrap it up. I just wanted to say thank you for everybody, and thank you for all the wonderful questions and being part of the conversation today. And thank you. It'd be lovely to meet you, Paul. I will definitely be in touch to have further conversations with you. We've got the menopause webinar, which is on the 11th of May. And on the 15th of June, Kim is actually going to do one called Supercharging your summer kitchen. We've decided to kind of break it out into little 1-hour things so that people can, if they can't come and have the whole functional medicine approach, they can start to have little bits of it and having a little bit more education of what's going on and how we are supporting our team. So thank you very much. We'll hopefully see you at our next webinar, and have a lovely rest of the evening.
Thank you so much,
Thank you, guys.
everybody.
Take care. All right.
Thank you.
Cheers.
Bye.
Bye.
Excellent, ladies.
It's still recording, Indra.
Yeah. Oh, no. Oh, no.